we're going to cover some flash presentations, and we really, like when I said, uh, have rock stars covering this. In the last portion of today's events, we have 5 world-renowned experts in fields covering important topics. I'm going to have a hook out here to keep people down to 10 minutes for each presentation, so we'll have time at the end for Q&As directed at all the people. The topics, again, are Richter's transformation, clinical trials, vaccines, CAR T therapy, and COVID-19 as it relates to the CLL community. I'd like to start by introducing Dr. Samir Parikh from Mayo, who will discuss Richter's transformation. Dr. Parikh is a consultant and an assistant professor of medicine and oncology in the Division of Hematology at Mayo in Rochester, Minnesota. His research is involved in evaluating the role of prognostic factors and novel agents in treating chronic lymphocytic leukemia. Each of the 5 doctors will be handing off their presentation to their following, to the colleague who's doing the next presentation. So Samir, we're going to start with you on the important topic of Richter's transformation. Thanks very much.
Thank you very much, Brian. My name is Samir Parikh. Thank you all for joining. I'm one of the hematologists at Mayo Clinic in Rochester, and I hope to talk to you about over the next several minutes about what you as a patient needs to know about Richter's transformation. And these are the topics that I hope to cover over the next several minutes as to what is this, how is this defined, what are some of the risk factors, how is this diagnosed, and what are some of our current treatment options. Historically, Richter's transformation was initially sort of described by Dr. Maurice Richter, who was a pathologist at the Bellevue Hospital in New York, almost 100 years ago, where in an autopsy finding in a patient who had CLL, he found that this patient had what was then described as a reticular sarcoma, or what is actually now called as an aggressive lymphoma. And that, over the years has led to the current definition, which is according to the 2016 WHO definition, where if a patient with CLL develops what is called as a diffuse large B-cell lymphoma, which is a type of an aggressive lymphoma, then that is defined as a Richter's transformation. Now, that's the vast majority of the way by which Richter's transformation occurs, but in a small proportion of patients, it can also develop as a Hodgkin lymphoma, and in even a smaller proportion with other types of aggressive lymphomas. So then the question is, how common is Richter's transformation? So in a study that we published many years ago now from Mayo Clinic, we looked at close to 1,600 patients who had a new diagnosis of CLL, and we followed these patients over time. And as you can see in this bottom dark solid curve, the risk of Richter's transformation at the end of 10 years was approximately 5%, which indicated that this was about a 0.5% per year risk of developing this process. In patients who needed therapy for their CLL, which was about a third of all the patients in this series, the risk was higher, was approximately twice as much at about 1% per year. Now, it is important to realize that this doesn't mean that treatment per se increases the risk of Richter's transformation. This just tells us that your CLL has high-risk features that needed therapy for CLL to begin with, and many of those same risk factors also may increase the risk of Richter's transformation. It's also important to note that a high proportion of patients in this study actually never, had any CLL treatment in the past, and those patients have a different outcome, and we'll talk about that as we go along. So, what are some of the risk factors for Richter's transformation? There are a number of, unfortunately unmodifiable risk factors for Richter's transformation. And by that, I mean, these are some of the genetic characteristics within the CLL cells, such as the presence of what is called as TP53 mutation or deletion 17p. You may have heard about these earlier today. Additionally, the presence of a mutation in a gene called Notch1 may increase the risk of Richter's transformation. Other risk factors include unmutated IGV8 genes, expression of other high-risk markers such as CD49D, etc., and clinical risk factors such as the presence of big lymph nodes and an advanced rise stage at the time of diagnosis. Like I said, most of these are non-modifiable because these are individual characteristics of your CLL cells that may predict the risk of transformation. And there is a higher risk just attributed to the presence of these. Now, CLL therapy, for example, as is listed over here with a combination of purine analogs and alkylating agents, did increase the risk in past. However, it is not entirely clear again if therapy per se increases the risk of Richter's transformation. So what are some of the symptoms and how do you evaluate someone who may have Richter's transformation? The vast majority of these symptoms include rapidly enlarging lymph nodes, fever, and fatigue. These are what are called as so-called constitutional symptoms. A lot of patients who have progressive CLL may have similar symptoms as well, and therefore it is imperative to determine if the symptoms are due to Richter's transformation or not. There are many laboratory findings that may suggest the presence of Richter's transformation, such as an increased serum LDH or increased serum calcium, a low hemoglobin and low platelet count. And all of these should prompt an initial workup that consists of either a PET scan or some sort of an imaging study, but ideally a PET scan and a bone marrow biopsy. Now, on your right, you will see how a PET scan really looks like. And there are areas within the body that will light up, quote unquote, when you do a PET scan. And when you see the increased uptake in the lymph nodes over here, that is manifested by green, yellow, and red sort of uptake, those areas indicate that these are metabolically active, and these are the ones that need to be biopsied. Unlike many other diseases where you can sometimes make a diagnosis without a biopsy, it is very important that a biopsy be done to be able to accurately diagnose Richter's transformation. And I cannot emphasize this point enough because we do not want to miss the diagnosis by not biopsying the correct site. And a PET scan really helps to identify the site of the biopsy. Now, once you have determined that a lymph node has been biopsied, then the pathologists try to figure out what kind of additional testing needs to be done. There are many things that need to be looked at, including the molecular markers, genetic risks, characteristics, etc. And then there are things that they can do to try and determine the relationship between CLL and Richter's transformation, meaning are these the same cells that have transformed from CLL to a large cell lymphoma, versus are these some different kinds of cells, and these have implications for as far as treatment is concerned. So, what about treatment for Richter's transformation? Now, there are a multitude of treatment options available. I think it's important to mention that unfortunately there is no standard treatment option available. I highly encourage all my patients to consider participating in a clinical trial, and there are several that are available. We've made progress over the years. However, we do need our patients to consider enrollment in a clinical trial to be able to advance the science and learn more. Now, in the context of where a clinical trial is not available, or if you don't qualify to participate in a clinical trial because of whatever reason, then I think there are many outside of trial clinical clinical trial treatment options available, but these are not FDA approved. So in anything that I mentioned here is not going to be really approved and available, but generally used on a regular basis. Now, as I mentioned, the clonal relationship between the underlying CLL and the Richter's transformation is important to determine as best as you can. And patients that have a clonally unrelated large cell transformation typically do better. Those who have not received prior CLL therapy generally do better. If you have received chemotherapy for CLL or chemoimmunotherapy such as FCR or BR in the past, and not any newer agents like ibrutinib, etc., typically R-CHOP-based chemotherapy along with these novel agents may be used. However, if you have received one of these newer agents such as ibrutinib or acalabrutinib or venetoclax, then there is a variety of things that can be done to treat the Richter's transformation. There is some data that supports the use of novel agents such as PD-1 inhibitors with nivolumab or pembrolizumab. These are checkpoint inhibitors that are used for many other types of hematologic malignancies. One of the things that is important to do is to try and think about what is the long-term strategy, which means would these patients benefit from the use of stem cell transplant as a consolidation, meaning after you get into a good response with any of these initial treatments, would a stem cell transplant be the next best step, or would CAR T therapy be the next best step? And I'll just leave you with these two slides at the very end. I'm not going to read through all of these, but these sort of summarize the current clinical trials that are available as I was able to pull through from clinicaltrials.gov. These is not an exhaustive list, but you can see here that these include the combination of chemotherapy with novel agents, or these are all novel agents with new BTK inhibitors, other agents like pomalidomide, everolimus, lenalidomide, etc., that are all being tested. And then there are a variety of immune checkpoint inhibitor-based treatments in combination with many novel agents that are being tested. And then there are bispecific antibodies as well. And so, this is an evolving topic. We are learning a lot about Richter's transformation. A lot yet needs to be done, but I think we have made a lot of progress, but a lot yet needs to be done. And so I'd like to thank you again for your attention. I'm happy to answer questions at the very end, and I'm going to hand it off to Brian, who's going to talk about clinical trials. Thank you.